have our treatment of male sexual dysfunction that by Dr. Prashant Baspure sir. Is a psychiatrist and the sexual medicine specialist practicing in Bangalore and is one of the directors of the Passion Fruit Relationship and Sexual Wellness Center. He is certified by the Oxford School of Sexual Medicine in the fellowship conducted by the European Society, which is the only multidisciplinary joint committee of sexual medicine and European Federation of Sexology. He has a vast experience in the clinical research and pharmacovigilance and given his service to renowned CROs like Quintiles and Inventive Clinical Health and currently also working as a medical advisor for one of the CRO and conducting global clinical trials in CNS and therapeutic areas. I welcome you, sir, and please proceed with your talk. Dr. Prashant Baspure, sir.
Yeah, thank you. So good evening, everyone. So it's been always treat to for all of us to hear Dr. Rupin Shah, sir. We all know that organicity is such a complex topic. However, he makes the topic so comfortable through his presentation. So it's always interesting to hear him. So thanks, I am Ashik and Dr. Nagapurkar, sir, who has given me this opportunity to speak on the topic of treatment in male sexual dysfunction. Also thanks all of the eminent speakers who are busy in the discussions and different topics since yesterday. Thank you very much. Can someone project my slide, please?
Yes, sir. Sharing. Just a minute. Is it visible, sir?
Yeah, it's visible. Can you move slide, please? Next slide. Okay. Actually, the topic is treatment in male sexual dysfunction, little vast topic. So I was in dilemma, what to cover, what not to cover. So I am making some small attempt here. So please accept my apologies if I miss something or if there's a mistake from my end. So since it is the only topic saying that treatment, but somehow I thought that even history taking is very important. Treating our patients, I'm not sure whether this topic is covered in previous lectures, but just I will just give just a touch upon on this briefly in history taking as well and different treatment modalities. Next slide, please. So we all know that still in this era, the sex is still a taboo or a stigma. So we all know that patient, they don't come very easily to us and seek treatment. There are different factors. They don't visit doctors. So basically, if we see, so the people, they feel that it's not an important part of life. It's just aging. Maybe after 40, you don't need because you're all settled, your kids are growing up. So it is not important aspect of our life. So they just ignore it. So, and they believe that this is just aging process and nothing can be done. And also they see that because physical problems are difficult and it affects, it hurts. So usually any physical component or physical issue, they reach to physicians thinking that that is a serious problem. But the sexual dysfunctions, they feel that it's not a serious problem and a doctor will not be able to do anything for that. So usually they don't visit doctors and they just keep waiting. Maybe it will go as time progresses, but usually if we see and we in our OPDs we see that people reaching after 10 years of the starting of problems, even the unconsummated marriages, the 15 years, 17 years we have seen. So usually they keep waiting to solve the problem on its own. So also there is a shame, of course. It is a kind of ego to any man. No man can accept that he's suffering from some kind of sexual dysfunction. So that led to not visiting doctor, and this is embarrassing for him. That is shame for him, and that is a stigma. So that's how these are the important reasons where they don't visit doctors and keep waiting to solve the problems. Now, what are the barriers? What are the barriers to discuss the sexual health with our patients? So there are two different barriers, like barriers from patient side, barriers from doctor side. So if we talk about the patient's barrier, you can see on the left-hand side, there could be some emotional factors, as I already discussed. There would be shame, there would be anxiety, there would be embarrassment. So obviously they don't visit. Age, already I spoke about it. Then perception that sexual functioning is not important, and also they don't understand that what is the sexual problem, so there is lack of awareness, they don't know anything about sexual issues. Then also because of lack of confidentiality, many people, they think that, if I visit any psychiatric hospital or if I visit sexologist, if I meet someone there, so the people would come to know, and or even the doctor, whether he will be able to maintain the confidentiality or not. So that fear, that anxiety keeps always patients away from the doctor. Lack of privacy also, which included in the confidentiality. And coming to barriers from doctor side, though the people are we are postgraduate and though trained, but still the sexual medicine or sexology is still we are hesitant to speak about. So there is sometimes embarrassment from the doctor side. So even sometimes we don't know what to ask, what not to ask to patient. So that keeps the barrier between patient and doctor. Sometimes, though, people, the doctors are postgraduate, but there is lack of training in sexual medicine. So this is not a routine topic, or it is not included in any postgraduate subject. So that lack of training keeps a barrier again between patient and doctor. Also, the lack of awareness of associated comorbid conditions. Suppose the specialty is something different, and for example, psychiatry, if you consider, so but the organicity contain different therapeutic areas. So that lack of knowledge sometimes, or lack of awareness sometimes, keeps the barrier between patient and doctor. Next slide, please. Now, how to prepare the patient once the patient is in your clinic. So these are just general points I'm going to discuss here, which will help us to treat patients maybe. So once the patient landed in your clinic or in your setup, so provide welcoming and comfortable environment. So how that can be done? So maybe once patient is waiting in the waiting area, waiting lounge, so we can basically display this different kind of literatures in waiting room and consultation room, which will give the idea about the what the service, what kind of service you are providing. That could be non-judgmental in nature, and what kind of illnesses usually the people would be having in sexual medicine. So that gives you certain idea before a patient enters in your cabin. So that's what introductory letters can be put in the waiting area. You should set the boundaries. Means you should explain patient that talking about sex is a routine aspect of healthcare, and ensure that patient doesn't feel singled out. That is very, very important. Also consider different cultural and ethnic differences and religious beliefs while treating patients. So you should set boundaries while seeing each and every patient. Also, you should explain the process, how the treatment would be. Mainly, this is a receptionist or receptionist job or front desk job once the patient, because patient would not be having any idea what is going to happen in the clinic. So once the patient entered in your clinic, so the receptionist should explain the process, how the consultation goes, what happens usually, so that patient would be comfortable and would not be that anxious before he or she meets you. Then examination is very, very important. Why it is important, examination of patient? Because being psychiatrists, we may hesitate sometimes to examine patient. We may not feel that it is important. So taking history and getting a psychological component or other triggering factor, precipitating factor, and then diagnosis. So we may miss to examine patient. But patient, I have seen that patient would always been asking you. So if you don't examine him at the end of consultation, himself, he would ask, doctor, I want to get examined. And so if you don't examine, so patient would not be really happy. And so we have seen that usually people they're very open to write down feedback nowadays. So they would go out and write open feedback that this doctor is not interested in treating patients. So it's very delicate issue. So kindly don't hesitate to examine patient, even if it is ED, it is PME, or any sexual dysfunction. I always wonder. So usually, many nowadays it's like people are open to, compared to the few years back, they're really open to take the treatment. And I have seen, in fact, the females, they have booked appointment for the partners. So they usually they come in the clinic, together. But sometimes, if man has a beginning sexual dysfunction, he would always hesitate. He would not tell his partner that he is seeking treatment and he is visiting sexologist. And he comes first, and so that the picture would not be that clear what is exactly happening, because we can't rely just on one partner for the diagnosis. So it is always recommended that the patient should come with the partner, and we should interview separately, because what I have seen is that when we interview separately, giving confidence to couple, that confidentiality will be maintained among you as well. Then really they open up, they vent it out, whatever happening with them, and you get many times different picture. If the husband tells one thing and the wife tells one thing, so you have to hear them separately. And once you sit together, so sometimes you have to be upfront and discuss their issues together. So that's the reason the partner presence is very much important. And again, coming back to why examination is important, because if you don't examine, you may miss the abnormality, like penile. If you examine penile during penile examination, the abnormality in penis, and sometimes there is basically a urethral abnormality, or sometimes when you examine testes, so you can't palpate one or both the testes. So that would be an issue, and which patient may not be knowing that that is a problem. So even sometimes you find nodule on the scrotum. Sometimes you miss the hydrocele if you don't examine, and different organic diagnosis like Peyronie's disease, etc. Coming to strategy to get the successful sexual histories, it's always good to introduce yourself, because many times the patient would be very anxious. He doesn't know which doctor is meeting. He will see on the social platform that some sexology clinic is there, and he's meeting some doctor. So he may not remember your name, or he may not even knowing your name. So it's always good to start the discussion with your introduction, your name, and your qualification, and what you are exactly going to speak during next half an hour or 1 hour. Again, explain the confidentiality. That will make, trust me, that will make the patient very comfortable, very easy. You can see sudden change, because when the patient is entering in the chamber, and patient is very anxious, restless, not maintaining eye to eye contact, and very hesitant to sit on the chair, looking around. And so that makes you also very uncomfortable. But when you explain about yourself, when you explain about the confidentiality, you can make a sudden change in the patient. Patient would be comfortably sitting back in the chair, getting himself relaxed. So that's the reason explaining the confidentiality is very important whenever you treat these kind of patients. Ask about patient's concerns. Of course, you should be very empathetic towards patient. Please listen empathetically, because if you are not showing that empathy, then definitely patient is not going to open what is having the symptoms, because you dig the symptoms, more you get the information. So once he knows that really doctor is empathetic towards me, so he will disclose, or he'll explain all the issues happening with him. Explain the need to ask more detail about question, because um, many times the patient may feel that why doctor is asking so many questions which is maybe not related to me. Maybe sometimes you have to go in detail of the childhood history, which is considering important, considering current issues, but the patient doesn't know about that. Hence you should always explain before the asking question that there may be some detailed questions, and there may be some odd questions also which you may not like, but this is what going to help me to diagnose you properly, so that the patient is on ease and comfortable, and he would not get offended with any of your questions. And reassure if appropriately, again, when during the conduct of your interview. So once the consultation is about to end, in the sense the history is taken, everything, and you are about to find a conclusion, before that you should tell that patient, you are going to examine the patient. If any investigations required considering his symptoms, you should tell him. And if any referrals required, so definitely you should tell them, so that patient knows that what is going to happen once he goes out of the chamber. And please don't forget to thank patient, because that is a positive gesture to us patient. And trust me, that only thank will help patient to come back for follow-up with the confidence. Next slide, please. Next slide, please. Thanks. Also, while taking sexual history, so all the physician must remember that it's very important. They should remember that they do not to be expert sexologists. So always people think that, I'm lacking of some knowledge. So how I'm going to treat patient, but it is not necessary that everyone should be expert here. So also do not to be have perfect sexual relationship with their own partner. So it's always the people, they think that, since the doctor is sexologist, so obviously he should be having compatible relationship, even sexual relationship with their partner, but it's not necessary. So do not need to be share the values of attitudes of their patients. Also, during the sexual history, to make them more comfortable discussing sexual matters, only important thing required is they should be good interviewers. That makes a great change in the patient approach towards you. And this good interview, it needs really different skill set entirely. Now, always there would be a dilemma in mind, what kind of questions should be asked to patients. So as I said, it should be a skilled interview. And I would always recommend that, we should definitely use open-ended questions rather than just closed-ended, that is yes or no. You will not get a clear-cut idea about the patient's problem. So start with open-ended questions like who the person is and what kind of the problem he is facing, or when did it start, something like that, and where he were all this time. So different kind of questions which starts from this W, so that the answer would not be definitely yes or no. And once you start asking these 4W questions, you will get more idea, and just make a note of it while interviewing. So that will help you definitely to make the proper diagnosis of the patient. So other questions like open-ended questions also tell me about something, maybe many things. So these are the all open-ended questions. We should always encourage patient to talk whenever it is needed, of course. And you encourage patient to explain the problems in his own words, because it's very important. Because when I see patient, I have seen that the people read Google and they diagnose themselves. And I hope that this is the same experience with all of you. They come with the diagnosis, and they would start their problem saying that, doctor, I'm having erectile dysfunction or premature ejaculation. But when we ask what exactly mean by premature ejaculation according to him, so the answer is something different. So even if the patient is using diagnosis himself, please encourage them to use their own words, so that you understand what exactly the problem is. You should give some liberty to give range behavior and ask for patient's experience. And always you can make out how the patient is. So you should urge patient to maintain the eye-to-eye contact. And whenever a patient is, or you should maintain eye-to-eye contact with the patient, and so that the patient knows that, yes, doctor is hearing me and doctor is really interested in my issues, and that is going to help me to get out of this problem. Keep nodding during the interview, so it shows the interest, our interest in patient. and in between you can use certain words like yes, go ahead. So that encourages patient to disclose all the issues happening with him, vent it out, so that patient is not restricting any information with you. General considerations, basically, while taking history, we never should make any assumptions about the orientation, about the gender. So even if anything evident in front of us, so please don't make any assumptions. Ask all the patients about the gender and partners, because even you see the gender, but indirectly you should ask whenever you ask the age. So obviously, indirectly you should ask the gender. Do not hesitate to ask that. And different sexual practices they have. So don't assume anything that the patient is talking about only vaginal intercourse, patient is talking only about the oral sex or anal sex. So don't assume anything. So whenever the patients start explaining the problems, you should ask what exactly the sexual practice he is having, so that you will have a definitive idea what he's talking about. You should be very clear. Don't use any medical jargon, because patient may not be knowing, because all patients are not the intellectual. So that if they don't understand anything, so please, that will make the problem more complicated. So use simple language with the patient. Clarify stories whenever necessary. Means if patient is telling something in detail, if it is required, definitely get some clarification from that. But if you see that patient is really going very circumstantial and this information is not really required for current problem, current issues, so you should be very upfront to stop the patient at that moment, and you should politely tell that patient that maybe we will not talk this at this moment. Maybe if it is required, I will ask the questions regarding this. So you also will not get it offended. So because anyway, that's not going to help you. So you should be very upfront sometimes. Be non-judgmental. Recognize the patient anxiety. The patient is very anxious, and that anxiety creates lots of problem while even discussing. So recognize that anxiety. Don't be very use your over value laden language that you should do like this, why you did do like that, I think you should do like this again. So this is some authoritative value laden language sometimes make patient uncomfortable, and so that will create problem in compliance and for follow-ups also. So please don't avoid usually the value laden language. Next slide, please. As we discussed about the open-ended questions, but yes, direct questions also very important, because many times if you ask open-ended questions, the patients go circumstantial and you may not get what you exactly want. So sometimes direct questions also recommended, like do you have a sexual partner at the moment? Because I have experienced that when this direct question is not asked, so the patient is very embarrassed to speak about the partners if someone is homosexual. So always they are hesitant to talk about partners. So then you will have some idea whether he is homosexual or not. But unless until you ask direct question, he will not give the answer. So check about the sexual partner. How long have been with your partner? That is also going to help you. How long the relationship is going on, and of course to know about the patient is sexually active with male or female, or involved with both. Unless and until you ask these direct questions, patient may not tell you this information. Next slide, please. So once you are done with the initial history taking, so once everything is done, so please don't forget to ask that, if I missed something to ask you. So that will make again patient comfortable, and something is really missed, patient definitely will tell you, and it may be important sometimes. And again, as I said, don't forget to thank your patient for their honesty. Now coming to the sexual dysfunctions. So the male sexual dysfunctions categorically divided into ejaculatory or orgasmic disorder, which include the ejaculatory disorders like premature ejaculation, delayed ejaculation, unejaculation, or involuntary ejaculation. And the next category is erectile dysfunction, and HSDD, that is hypoactive sexual desire disorder. So we'll start with erectile dysfunction. So mainly the erectile dysfunction is divided into primary ED and secondary ED. And we know that what is primary ED? Mainly it is a manifestation of erectile dysfunction with the first sexual activity. Mainly most of the time it starts in the adolescent age. So that is what the primary ED is. And what is secondary ED, which is also called as acquired ED. So what does mean by acquired ED? It is a manifestation after a period of normal sex life. So initially, the person was doing well, but due to some other factors, the patient developed erectile dysfunction. That's the reason it is called as acquired erectile dysfunction. Now, what are the etiology of erectile dysfunction? So these are the heading basically: the psychogenic factors, lifestyle, cardiovascular risk factors, endocrine factors, iatrogenic factors, medical disorders, and penal factors. So the psychogenic factors may include the psychosexual development, maybe sexual sexual experiences, maybe bad sexual experience in the past, and sexual orientation problem the patient may have, and there could be some partnership issues, so that may lead to psychogenic factors. Now the lifestyle factors may include the permanent different stress factors, maybe the sedentary lifestyle, which nowadays we see many IT people sitting at home, even though it is working from home. So obviously I see that 12 to 15 hours people, they are working, so there is no exercise and sitting at home, and the eating more, so that leads to many problems which we are seeing basically last more than a couple of years now. So sedentary lifestyle is one of the lifestyle issues. Also we see mainly like nicotine and alcohol abuse and different drug addictions, so that can cause mainly the lifestyle factor. The organization is covered by Dr. Shastra already, but just in brief, the cardiovascular factors, we know that hypertension, dyslipidemia, then diabetes mellitus, then any other cardiac issues can lead to erectile dysfunction. So endocrine factors, if we talk about, then there are different issues like hypogonadism, then the prolactin level increases, that is hyperprolactinemia, and even the thyroid disorders can lead to the erection problems. Iatrogenic factors, we all know that what is iatrogenic what is iatrogenic factors. So mainly if we talk about when we treat the patient, many times the drugs itself lead to sexual dysfunctions, like that's what it is called as drug induced sexual dysfunction. Or the mainly if I talk about the which drug causes the sexual dysfunction, we all know that different metabolic disorders been treated, and mainly the hypertension, the treating antihypertensive itself can cause the sexual dysfunctions. Mainly we know that the beta blocker, even in psychiatry we use the propranolol basically. So basically the mechanism of beta blocker, if I'm right, so it causes the contraction of the smooth muscles, especially the cavernous smooth muscles. So that leads to erection issues. Also, it can decline in serum testosterone. And if I remember correctly, it's the only beta blocker is nebivolol that basically it won't cause major sexual side effects, that exert mainly the it dilates the penile arteries, and there is an increase in nitric oxide. So that's why it is paired among the antihypertensives. So there are different medicines like clonidine, then thiazides, spironolactone, so which can cause the sexual dysfunction. So other medicines may be cholesterol lowering agents. Then in neurology, if we talk about the antiepileptics, that causes increase in SHBG, and that lowers of course, the free testosterone, that causes the problem in erection. And certain routine medicines we use in practice, like antiemetic, like metoclopramide, which inhibits the biosynthesis of testosterone, and that causes sexual dysfunction. Even as a psychiatrist, we know that lot many antipsychotics or psychotropics been prescribed to the patient, which causes mainly if we treat antipsychotics, obviously these are certain antipsychotics like dopamine antagonist, mainly the second generation antipsychotics, which causes hyperprolactinemia. Prolactin level goes up, and that causes the desire issue and the arousal issue and even the erectile dysfunction. And again, in psychiatric practice, we know that tricyclic antidepressants like imipramine, clomipramine, then amitriptyline also. Even mainly the prolactin increased by certain second generation antipsychotic like clozapine and amisulpride. So that makes the issue with patient, and there would be poor compliance with the current medication from the patient side. Even the different kind of SSRI, we know that the serotonin is main neurotransmitter in psychiatry, which increases serotonin level in so basically presynaptic cleft, the serotonin level increased, and this increased serotonin level activates the postsynaptic neurons, and that mainly increases again the serotonin level. And then initially this, once the serotonin is increased, it is regulated by the 5-HTA autoreceptors, and initially they lower the serotonin level. However, the chronic use of the SSRIs, that basically downregulates the mechanism of these autoreceptors and keep increasing serotonin level, and that's the reason they cause these kind of sexual side effects. Next slide, please. So as I spoke about other factors mainly, but I want to touch upon majority of the psychological factors. So we all know that because organization is well covered, so I will psychiatry perspective, I will keep talking. So mainly the personality characters, we know that there are always cluster B versus cluster C. So we have seen lots of relationship issues and different kind of personality issues in male and female. Also, these are the headings basically, the cognitive factors, performance anxiety, psychopathology, which includes depression and anxiety disorders, the partner dysfunction, relationship issues, and the contextual factors, which we will see in next few slides. Next slide, please. Now we'll mainly talk about the cognitive factors, that what different sexual beliefs and myth the men would be having. So the people or men who are associated with ED, they have always this macho attitude. So they feel that the man should be always ready for sex, and he should be always having capacity to satisfy any woman, and he should be always intense with his sexual activity, and he should erection immediately before start the sexual activity. The penis should be always erected, and so that causes a problem. So the attitude in ED patients, these are the different myths or false belief, I would say, it is associated with the ED. Then catastrophization of woman's reaction means catastrophization means assuming that something bad would happen when I attempt the sexual activity. So that creates a problem, that the man may think that if I fail, then how she's going to react to this incident, and how she will take this, and that stops him attempting next time. So that is what the catastrophization of woman's reaction to man's failure. Also different beliefs that for a man that demands for woman's sexual satisfaction, and the importance of coitus and necessity of simultaneous orgasm. Most of the men, they think that the orgasm, both the partner, that is male and female, should get orgasm at the same time, and if I get orgasm before her, so how she will take this, so I would not be able to satisfy her. So these are different sexual beliefs and myth the male patient with ED would be having. Next slide, please. So these are the macho beliefs. As I said, a real man is always ready for sex, A real man has sex frequently, and these mature beliefs are more frequently in men with the ED. Next slide. The cognitive factors continued mainly. This is the definition of sexual schema. These are the sexual schema is the cognitive generalization about sexual aspect of oneself, which have derived from the past sexual experience are manifest in the current sexual experience. So once the person having the performance anxiety, he would always remember the previous activity where he had a failure, and when he is attempting next time, then he remember always that past experience, and that creates a problem. Then beliefs of the negativity, like incompetence, are more frequent in men with ED. The man would always think that I maybe get rejected from my partner, or I'm incompetent, and I'm something different from others. So these negativity, the repetitive thought, obsessive thoughts keeps coming in the person's subconscious mind, and that creates a problem when your patient is attempting. So as I was talking about automatic thoughts, so once the patient had a failure in maintaining erection, so that creates an image, and that leads to negativity, lack of confidence, and most of the times the man would not hesitate to try next treatment with the partner. But again, whenever he tries next time, so these automatic thoughts would come in the subconscious mind, keep bothering him, and obviously that sympathetic tone get activated, and a patient would be having the erectile dysfunction. Next slide. So cognitive factor continued here. So mainly the attention we're talking about. This is the definition of attention, which is the cognitive process, and mainly concentrating on the aspect of environment while ignoring the other things. So whatever the person is doing that time, he would be concentrating on the current environment and not on the outside things. So what studies have shown that the healthy individual they get more aroused when they see their own erection. So that is a positive feedback for them. So seeing their own reaction, they get more arousal, and they lead to great performance. So that's what the healthy individuals do. However, they may get disturbed by the outside disturbance, and that may get a disturbance in the erection. However, if we talk about the men with ED, so they are mainly more aroused, not with their own erection, because there's always performance anxiety. So they may get aroused after seeing the partner's response during the activity. So that is the difference between attention in healthy and the person having ED. Next slide. So this is what about the performance anxiety, which is a process that involves the interplay between the cognitive, affective, and behavioral, and the physiological response. So you can see here the brain is stimulated. However, during the sexual activity, during foreplay, based on the previous experience, that automatic thought would come in the subconscious mind that I may lose my erection, or I will lose my erection. That increases the fear, that activates the sympathetic tone, and obviously man would be ending a loss of erection. The same person may get good erection when he's masturbating, because he doesn't have to show his performance to anyone, and he's very much comfortable all alone. So that is the difference between the person when he's participating in some sexual activity alone and with the partner. Next slide. In psychopathology, of course, certain psychiatric illnesses, that depression, anxiety disorders, even schizophrenia. We all know that in schizophrenia, around 50 to 60% schizophrenic patient themselves, they are having sexual dysfunctions without any even treatment. So that is how the psychopathology also creates a problem in sexual dysfunctions. Next slide. Also, relationship factors also plays role here. Relationship quality, physical distancing, the partner's sexual dysfunctions. Maybe a man having initially not having any erection issues, but when he is having sex with the partner, female partner, and if she has some phobia or fear of pain, or actually having a pain and there is vaginismus. So obviously he will stop the sexual activity, or he may lose the erection. That also in turn gives negative feedback, and he may lose his confidence. So the partner sexual dysfunction also one of the factor in relationship. Then partners disapproval of medication means, as we know that the people, they read lot about the medications, and Dr. Shah already mentioned that sometimes they would not be willing to take the medications considering the side effect profile. So even if we explain them the mechanism of action and the expected side effects with the drug, so again they go back home and they read Google again, and so many things they find against the medication. So obviously the female partner may disapprove, or she may not encourage patient to take the medication. So that is one of the relationship factor here with the partner. The contextual uh, factors like, the financial struggle, unemployment, which we have seen last couple of years due to COVID, that leads to lots of stress factor, lots of financial burden on them. That creates a problem. Fatigue from childbearing, apart from work stress, if they have kids, their issues, so that also creates a problem and causes sexual dysfunction. And the environmental factors, which because in metro cities we have seen that the husband and wife both are working in different shifts basically. The wife is working general shift, and the husband is working night shift. So it's very rarely they meet during weekdays, and again they're totally fatigued during a whole week, and again only weekend they get to have this kind of sexual activity, but again some other things they would be busy and keep postponing these things. So these are the contextual important factors. Now, last presentation we have seen the organic causes, basically, but how to differentiate between organic versus psychogenic ED. So this is a small a few points I have put here. So we have to see the characteristics. Basically, when did the problem started? So if we all know that organicity is a gradual process. It is a chronic process. So obviously, the onset of problem or onset of erectile dysfunction is gradual. Versus psychogenic, it is a sudden. Means still yesterday patient was doing well, and something triggered today, and patient starting having erection issue. That is a sudden onset. So that will help you to differentiate between psychogenic versus organic. The presence of symptoms, if it is a organic cause, so obviously the erection issue would be there always throughout the course of illness. But if it is a psychogenic ED, so sometimes patient gets normal erection, sometimes not. So it is on and off problem. So if we talk about the nocturnal, that is morning wood, so in organic cause, so we don't see any early morning erection in organic cause, but this is very interesting because in my patients, I have seen that even it is very clear-cut diagnosis that is psychogenic ED. But in those patients also, if they're having some very severe anxiety along with the disturbed sleep, including the psychiatry issues like depression, anxiety, and big time stress, those people also, they usually don't get morning erection, or suddenly last 2 months it goes down drastically. So I have seen in psychogenic ED as well. So organic risk factor, yes, and there are no any organic risk factors in psychogenic ED. Relationship problem would be secondary cause in organic ED, but if you take the history, when you go back in the past, so you would see that the primary cause is the relationship among partner, relationship issue that causes ED, so that will lead to psychogenic ED. Next slide, please. Now, treatment, basically, it's been discussed in detail nicely during last presentation, but again, just psychiatry point of view, psychiatry perspective, I will touch upon certain things like this is what the psychosexual therapy, about mindfulness, the CBT therapy, the couple therapy usually we do in our setups. So you should teach the basic mechanism of mindfulness, how the patient should use mindfulness, and that may help patient to as add-on treatment along with the pharmacotherapy. Even CBT, mainly we train them about their negative thoughts and the interference, and identifying the negative bias. So we should teach them and that this CBT will also help as add-on treatment to their current treatment. Obviously, if there are certain many issues, the interpersonal conflicts and the personality issues among couple and different stress factors, different issues, that is the primary cause. So obviously, no pharmacotherapy will help to improve the patient's ED. So in those cases, this couple therapy is advised, and they have to spend good amount of time to discuss their issues. There are different sessions, and couple therapy can be conducted in these kind of patients. So this is, I will just fast little, I'll move little fast on this slide. This is the algorithm. Which is more talk about the organicity, the hormonal cause, psychogenic cause, and the cardiovascular risk factors. And if anyone is non-responders to this kind of treatment, then what should be done? So it is given in the algorithm, but just we'll move fast. Please, next slide. So that is what the implant which we discussed in previous presentation, that is the last resort, penile implant. Next slide. The pharmacological treatment in ED, it's been again discussed in detail, but in like PDE5 inhibitors, we know that sildenafil, tadalafil, vardenafil, and many times the patients may show non-responders. Patient may be non-responders. So instead of changing medication directly, I may recommend that you can re-counsel the patient and educate patient that it may happen. It may be due to because of your severe anxiety, because if it is a severe anxiety, the PDE5 inhibitor will not work. So once you educate patient, the patient may respond to the same dosage. Also, we should check about the other concomitant diseases which can be contributory factor for their current erectile dysfunction. So this is what we should do in non-responders. And if, for example, if patient is having the thyroid issue, hyperthyroidism, and only giving PDE5 inhibitor will not help. So in those patients, we should treat the thyroid disorders. So obviously, once the TSH level goes up, so patient may get improvement in their sexual dysfunctions. Then you may switch to the another PDE5 inhibitor and try the things. And so already been side effects been discussed with the PDE5 inhibitor, but yeah, so headache is more with the sildenafil. That's what we have seen. Even the flushing is more with sildenafil. The dyspepsia is more with the tadalafil. And the last one, maybe not the least, but back pain, which we usually seen, that is more with the tadalafil. And of course, the more some kind of serious effect with the color visual disturbance, that is more with the sildenafil. Then other than this oral the PDE5 inhibitors, there are some topical therapies. We have seen the prostaglandins, obviously this Muse, then vasoactive drug used in intracavernosa cell injection therapy, which has been discussed. Vacuum devices, we know, penile implants been discussed, and the surgeries as well. Next slide, please. So that was all about the erectile dysfunction. Coming to the premature ejaculation. So there are different definitions. I don't want to go in detail, but these are the headings. The 5 different definitions have been used by the sexologist pioneers. Then DSM-5 give one definition, the ICD-10, and even American Urological Association gives one definition, and the ISSM, that is International Society of Sexual Medicine. Next slide. So the premature ejaculation definition we can see here. The premature ejaculation is the dysfunction which is characterized by ejaculation, which is always or nearly always occurs sometimes prior or within about 1 minute after the vaginal penetration, means sometimes before penetration or within a minute of penetration. So this is very important definition of the premature ejaculation one should know. And inability to delay the ejaculation against the will, so that is one fulfill the criteria of premature ejaculation, and that leads to distress, the frustration, and the relationship issues and avoidance of sexual intimacy. So that fulfills the criteria of premature ejaculation. So this graph, basically the sexual response cycle talks about What exactly happened in the premature ejaculation? You can see two different phases here. First, we'll discuss about uh, the the normal sexual response. So where there is the normal excitement initially, there's a plateau after penetration. There's a peak here, which culminated. That is a peak pleasure the person gets, and the last phase is resolution. So this is graph, wide graph you can see, but exactly opposite in premature ejaculation patient. You can see here the left extreme left side, which is highlighted by green and the orange color here. So which is the patient, there is a steep excitement phase with normal erection initially, and the plateau is very short, and immediately rapid ejaculation, which is a peak here. The patient got the orgasm, and there is immediate resolution. So this is the small width graph talks about the premature ejaculation. This is what happened in the premature ejaculation patient, the sexual response cycle. So how the treatment strategy can be done? So specifically you should ask questions to the patient, because they directly will tell that I'm suffering from premature ejaculation, but they may not. So after taking detailed history, I have seen that some patients take more than 5 minutes after penetration, but due to confusion or due to some factor or due to some lack of knowledge, they come with the problem. So there is good foreplay, they take good amount of time for ejaculation, but because of the wrong beliefs, they come clinic. So you should ask specifically how much time it take to ejaculate after penetration, whether it is within seconds, within 1 minute, within 2 minutes, or actual time after penetration. Also ask about the partner, means what is the partner concern. So when you interview differently, so when you may get different information, the partner may says that it takes 5 minutes, I'm okay with that, so she's not worried about, she's not distressed. So interviewing different separately, that will help you to know exactly how much time the patient is taking. Next slide. What are the consequences of premature ejaculation? Obviously, if it is not treated, so we have seen that that it reached to the level of divorce. There are so many couples we see on regular basis who doesn't seek the treatment, and once they get married, so different issues starts along with the family issues, and in that this sexual dysfunction will trigger the matter, and they end up into having divorce. So obviously it hurts the relationship. And once the patients start this kind of problem like premature ejaculation, it impacts sexual confidence, and which led to his general confidence also, which impacts his social confidence as well as the performance in his profession. So these are the consequences of premature ejaculation. Personality factors, again, we have discussed. I don't want to spend time here. Next slide. So mechanism, basically anxiety related to premature ejaculation. We all know that the sympathetic and parasympathetic tone. So once the patient is anxious, the heart rate goes on increasing. It means the sympathetic tone is activated, and that may cause of the erectile dysfunction and the premature ejaculation too. So, which basically the man focus is distracted here. Once the sympathetic tone is activated, the man's focus is distracted, and that impacts the level of arousal, and it's difficult to get the arousal and maintain the erection, and even there would be early ejaculation. Next slide. What is the etiology of P? So we all know that there are two kinds of the premature ejaculation divided into lifelong P and acquired P. What is lifelong premature ejaculation? Means the premature ejaculation problem is there from the day one of the sexual life, and the acquired P is mainly basically it's initially the patient would be having normal enough satisfactory time patient take to ejaculate, but however it is triggered by something, and that leads to premature ejaculation. So there could be some different reasons in acquired premature ejaculation. You may see the neurophysiological factors. Neurophysiological factors means there could be some hypersensitivity and hyper excitability of the glands, so that lead to premature ejaculation. And we also see when you examine the patient, so we all may see the penile anomalies, that is urethral abnormality, and sometimes the patient, if he's circumcised, then we have seen that for a glans circumcised, the main reported decreased sexual pleasure, and lower orgasm intensity. So that is one of the neurophysiological factor for the premature ejaculation. So if we talk about the endocrine factors, we all know that hyperthyroidism patient, they are more prone for premature ejaculation, and the prolactin. So we have seen that the patients with premature ejaculation, they have very low prolactin level. What are the andrological factors? So penile anomalies we discussed. There could be some prostatitis, chronic prostatitis can cause the premature ejaculation. Then BPH, that is benign prostatic hyperplasia, and urinary tract lower urinary tract symptoms that also can be cause the premature ejaculation. So these are the uroandrological factors. Next slide. So we spoke about the what other etiology, basically the psychological factors, neurogenic factors, and the secondary, so some certain metabolic disorders like diabetes mellitus can lead to premature ejaculation. Next slide. How you make the diagnosis of premature ejaculation? Basically, take the sexual history in detail, as I asked, the open-ended question, closed-ended question. So that should be asked in detail, and so which will confirm whether really patient is having premature ejaculation or not. And as I said, examination is very, very important in any kind of sexual dysfunction. So in lifelong premature ejaculation, so routine clinical examinations is important. However, investigations may not be needed. So there is difference in the approach. And in acquired premature ejaculation, because it is triggered by something else, then physical examination is definitely warranted here. And also certain kind of investigations like hormonal assessment, hormonal evaluations is recommended here. So now coming to the treatment of premature ejaculations. So the first bullet talks about the patient's behavior who seeks treatment when they reach our clinic, but they try many things before they seek treatment. For example, based on their knowledge, for example, they divert their attention. So that is what their behavior is. Before seeking treatment with the doctor, they try all these things first, and when it is not helping, they end up into consultation with the doctor. Sometimes they basically masturbating just before the sex, so they may think that it may help to take time to ejaculate. They keep themselves engaged more frequently in sexual activities, or some position they may be more comfortable, like woman on top position may lead to little bit delayed ejaculation, so that those things they try. Sometimes themselves they try the alcohol and other recreational drugs, which will also help them to delay the ejaculation a little bit. Some people, they use the long lasting condoms, and that may help them to delay the ejaculation. Sometimes we have seen the herbal medicines they use, and even because of lack of knowledge, whatever the sexual dysfunction is, they use Viagra before seeking treatment from the doctor, and then they visit doctor and consult with you. So then coming to pharmacotherapy, we know that there are certain topical anesthetics, the lidocaine, lignocaine 2% available, but unfortunately, if it is not used properly, so that itself makes the penis numb and get into another trouble of erectile dysfunction. So that may again lower the confidence of the patient. Some SSRIs, we already discussed the mechanism of action of SSRI, but there are certain SSRIs like paroxetine, which we use 10 to 40 milligrams per day. So it is found that it may increase the ejaculation or time 8-fold compared to baseline. And fluoxetine, we usually use 10 to 40 milligrams per day. What we found that it increases the ILT 5-fold compared to baseline. Sertraline similarly 50 to 200 milligram increases 5-fold, and the citalopram 20 to 40 milligram only 2-fold compared to baseline. And on-demand dapagliflozin may help because of short half-life and the initial SSRI transmission in the synaptic cleft. that explains the mechanism of dapagliflozin and can be used 30 milligram of 60 milligram on demand basis. Tricyclic antidepressant can be used. We have seen certain physicians prescribe tramadol for premature ejaculation. Sometimes PDE5 inhibitors may help because it helps to maintain the erection. So even if after ejaculation, the patient maintain erection for some time, and that may give the satisfaction. Surgical approach, rhinolotomy, penile neurotomy can be done. And obviously treating comorbid conditions, which I discussed, the treating thyroid issues, treating like prostatitis with antibiotics may helps the treating premature ejaculation. So certain behavioral technique which I missed, I guess, here. So usually we explain patient to use stop and start technique, sometimes squeezing technique, and sometimes sensate focus and sex therapy explained by Marston and Johnson. So that was all about the premature ejaculation. Coming to delayed ejaculation, we all know that the definition of delayed ejaculation, which is a recurrent delay in orgasm after normal sexual excitement phase without individual desiring for the delay. He doesn't want, but still it is going on and on. So that fulfills the criteria of delayed ejaculation. The disturbance, it's very distressful for the man, and that also causes frustration for the female partner. So that fulfills the criteria for delayed ejaculation. If we talk about the epidemiology, it varies from incident rate of 3 to 40% in men. Next. What is the clinical presentation in delayed ejaculation? So we have seen that maybe the person is not able to ejaculate within stipulated time. So delayed intravaginal ejaculation. If you take history, patient may tell that when he is engaged in oral sexual activity, he is not able to ejaculate. He is taking too long time. And sometimes mutual masturbation they are doing, still it is taking time. So that could be the clinical presentation in the clinic. And mainly any kind of, it is not just about oral, it is not just about vaginal sex, but any kind of sexual activity they are engaged, it is taking long time to get the orgasm or to ejaculate. So these are all the clinical presentation of the men with delayed ejaculation. Next. So it can be psychogenic or it can be organic delayed ejaculation. Psychogenic, there could be different stress factors. Again, I don't want to talk about detail. Those stress factors. Also, sometimes the man doesn't want pregnancy. We have seen that there is no other issue. The patient can ejaculate while masturbation. However, when they engage into sexual activity and he is suspecting ovulation period and he doesn't want the pregnancy to happen. So usually there is a control and that can cause the delayed ejaculation. So that is one of the factors psychologically. So the organicity, we different the different organic delayed ejaculation causes sometimes secondary to neurological lack of sensitivity, means the sensitivity is not there. So that can cause the delayed ejaculation. Even we have seen that the spinal cord injury the patient is having, so that can also lead to delayed ejaculations. That is one of the organic delayed ejaculation cause. Now, treatment which we clinically experience that sometimes premature ejaculation is a little bit easy to treat, but in clinical practice, sometimes the man with delayed ejaculation may not show improvement, even if the person is coming very regularly for the treatment. But these are some options we can use. The cyproheptadine, which is antihistaminic drug, can be used 4 to 12 milligram on demand basis. Euhimbin, some paper says that 5 to 15 milligram on demand again. And usually we use bupropion, again 150 milligram per day. So we have seen that there is some kind of improvement in delayed ejaculation. Even the different kind of psychosexual therapies, the sensate focus technique, and that can be counseled to the patient. And even lifestyle and counseling that may encourage patient, even if there is no improvement, that may help. And sometimes some kind of the vibrators, even male vibrators are available for the patient. So that may help to get the ejaculation while having sex. I think I'm done with the presentations. That's all from my end. Thanks a lot once again.